Finals SAQ83, Meningococcal Septicaemia. A 4-year-old child is admitted to the emergency department with suspected meningococcal septicaemia. You are asked to help resuscitate the patient prior to transfer to a tertiary center. A. List the clinical features of meningococcal septicaemia. Non-specific symptoms and signs includes fever, chills, shivering, ill-looking child, lethargy, headache, the patient being irritable or unsettled, nausea and vomiting, abdominal discomfort, anorexia, muscle ache, joint pains, respiratory symptoms, shortness of breath, tachycardia, tachypnea, and rapid deterioration in illness. More specific symptoms and signs includes altered mental state, toxic or moribund state, seizures, photophobia, neck stiffness, unconsciousness, hypotension, shock, cold hands and feet, capillary refill time greater than 2 seconds, mottled skin, non-blanching rash and leg pain. B. Outline the initial management of this patient. This is a medical emergency. I would assess and manage the patient simultaneously following an ABCDE approach. Request senior help. Give ceftriaxone 80 mg per kg IV without delay. Initiate communication with pediatric retrieval service and download guidance to assist with drug dosing. Airway. Assess airway patency. Consider need for immediate intubation for either respiratory compromise or moribund state. Breathing. Assess respiratory rate, oxygen saturations, provide 100% oxygen. Circulation. IV access, ideally 2 cannulae. Obtain intraosseous access if IV access is not immediately feasible. Assess for signs of shock, such as capillary refill time greater than 2 seconds, mottled skin, tachycardia, hypotension, cold hands and feet, toxic moribund state, altered mental status, decreased conscious level, and poor urine output. Treat shock with up to 3 boluses of 20 ml per kg, balanced crystalloid solution over 5 to 10 minutes. At the 3rd bolus, intubate and ventilate the child. Ensure a cardiostable induction with ketamine and rocuronium. Ensure that emergency drugs are ready. Further fluid boluses may be required. Consider using blood. Consider contributing causes to shock such as acidosis and extravasation of fluids. Initiate vasoactive support as per retrieval team guidance. CNS, continue to monitor the child's mental state and need for intubation. Assess for signs of meningism. Exposure, examine the child, look for rash and check for capillary blood glucose. Send investigations as detailed under section C. C. Which investigations will guide care? This includes full blood count. Increased white cell count supports the diagnosis of meningococcal disease, although it may be normal or even low. Thrombocytopenia may contraindicate lumbar puncture. Blood administration may be required. Surviving sepsis guidelines suggest against the use of blood if HB is more than 70 grams per deciliter in a hemodynamically stable child. Coagulation screen. Management of DIVC may be required. Results may contraindicate lumbar puncture. Blood glucose levels. Hypoglycemia may occur due to resuscitation with non-sugar containing fluids and critical illness. Supplementation with dextrose may be required. Electrolyte abnormalities must be corrected. Raised CRP is usual in meningococcal disease but may be normal. Arterial blood gases guides the need for intubation and adequacy of ongoing ventilation. Acidosis may require treatment if shock is persistent, despite fluids and vasoactive drugs. Neisseria meningitis whole blood PCR confirms diagnosis if positive. If negative, CSF should be tested for Neisseria meningitis and Streptococcus pneumoniae PCR. Blood cultures may confirm infective organism, therefore guiding antimicrobial treatment. CT brain may indicate different diagnosis or may contraindicate lumbar puncture if features of raised ICP are present. CSF studies, PCR or culture may be diagnostic of underlying cause if negative for meningococcus. Causative bacteria determine the choice and duration of antibiotics. For all patients, examine CSF opening pressure, CSF WCC and differential, CSF protein, PET CSF and serum glucose, CSF gram stain, blood and CSF cultures, CSF PCR for meningococcus, pneumococcus, HSV1 and 2, VZV and enterovirus. Further investigations for immunocompromised patients, returning travelers, and investigations for autoimmune encephalitis are included here for completion. Comments: 67.6% pass rate. This pediatric emergency is commonly encountered both in secondary and tertiary centers. Although the question was answered satisfactorily, marks were lost by not calling for help, inappropriate fluid resuscitation, failure to communicate with tertiary center for advice or to summon pediatric retrieval team. Meningococcal disease may present as meningitis, septicemia, or both. Additional SAQ1. You are called to the emergency department to see a 2-year-old child who presents with 4-hour history of high temperature and drowsiness. On examination, there is prolonged capillary refill time and a non-blanching rash. A presumptive diagnosis of meningococcal septicemia is made. A. What are the normal weight, pulse rate, MAP, and capillary refill time of a child this age? Weight is 12 to 17 kg. Formula is 3 times age in years plus 7. Pulse rate 95 to 140 beats per minute. Mean arterial blood pressure 58 mmHg. Formula is 1.5 times age in years plus 55. Normal capillary refill time less than 2 seconds. B. Define the appropriate resuscitation goals for this child and outline the management in the first 15 minutes after presentation. Appropriate resuscitation goals includes capillary refill time less than 2 seconds, MAP 58 mmHg, normal pulses with no differential between central and peripheral, warm extremities, urine output more than 1 ml per kg per hour, and normal mental status. Answer for initial management has been discussed in the previous SAQ. C. After 15 minutes, the child remains shocked and unresponsive to fluid. What is the most likely pathophysiological derangement in this child's circulation, and what are the important further treatment options? The child has developed septic shock. In addition to organ dysfunction occurring as a result of the child's physiological response to infection, shock has developed due to circulatory, cellular, and metabolic dysfunction. Consequences include vasodilation, activation of inflammatory and coagulation cascades, capillary leak, dysfunctional oxygen utilization at cellular level. The answer to the second part of this question is the management of the child from the third fluid bolus onwards when intubation is recommended, as discussed in the previous SAQ. Additional SAQ 2. You are called to the emergency department to review a 2-year-old baby who is unwell and suspected to have meningococcal septicemia. A. State the normal weight, heart rate, MAP, and capillary refill time of a child this age. The answer to this question has been discussed in the previous SAQ. B. The MAP is 50 mmHg. State how you would restore the circulation. Give an IV or IO bolus of balanced crystalloid 10 ml per kg. Repeat up to 60 ml per kg, titrating against markers of restoration of circulating volume, such as capillary refill time less than 2 seconds, normalization of blood pressure, normalization of heart rate, urine output greater than 1 ml per kg per hour, normal mental status or level of consciousness, and normalization of lactate. Assess repeatedly for markers of fluid overload as an indication of when to stop further fluid boluses, such as new or worsening hepatomegaly, and signs of pulmonary edema. C. Name the antibiotic and its dose that should be given immediately. Ceftriaxone 80 to 100 mg per kg, maximum of 4 grams. This should cover H. influenza and strep pneumonia. D. List 4 indications for intubation, apart from those relating to airway or respiratory concerns. Circulatory indications includes ongoing shock despite 40 ml per kg or more fluid resuscitation, and post-cardiorespiratory arrest. Neurological indications includes reduction in or fluctuations of GCS, need to control intractable seizures, evidence of raised ICP, and to facilitate transfer for neuroimaging or to tertiary center. E. State 3 abnormalities that you might see on the patient's blood test. Abnormalities that may occur includes hypoglycemia, acidosis, hypokalemia, hypocalcemia, hypomagnesemia, anemia, and coagulopathy. F. This child continues to be hypotensive despite resuscitation with IV fluids. State further 5 steps in your ongoing management. This includes adrenaline or noradrenaline infusion via peripheral cannula if central access is not available, vasopressin infusion if high-dose catecholamine infusion is required. Consider IV hydrocortisone, correct acidosis, correct hypocalcemia, advice from pediatric intensivist or retrieval service. Additional information: pediatric sepsis. Definition of sepsis. In 2016, the adult sepsis 3 definition is life-threatening organ dysfunction caused by a dysregulated host response to infection. Application of this definition to children has been attempted. Formal revisions to the 2005 pediatric sepsis definitions remain pending. Several methods to identify acute organ dysfunction in children are currently available. Research validating an age-adapted SOFA scale demonstrates that this scale may be more accurate in identifying children most at risk compared to SAQ criteria, plus known or suspected infection. The 2005 nomenclature for sepsis. Severe sepsis is defined as greater than or equal to 2 age-based SAQ criteria. Secondly, confirmed or suspected invasive infection. And 3, cardiovascular dysfunction, ARDS, or greater than or equal to 2 non-cardiovascular organ system dysfunction. Septic shock is a sepsis subset with cardiovascular dysfunction, which includes hypotension, treatment with a vasoactive medication, or impaired perfusion. Septic shock is sepsis accompanied by significant circulatory, cellular, and metabolic abnormalities. When cardiovascular organ dysfunction exists in the presence of sepsis, the child is considered to be in septic shock. Consensus criteria define cardiovascular organ dysfunction as despite giving isotonic IV fluid boluses 40 ml per kg or more in 1 hour, there are presence of decrease in BP less than 5th percentile for age, or systolic BP less than 2 standard deviations below normal for age, or need for vasoactive drug to maintain BP in normal range, or 2 of the following: unexplained metabolic acidosis, base deficit more than 5 MEq per liter, increased arterial lactate more than 2 times upper limit of normal, oliguria, urine output less than 0.5 ml per kg per hour, prolonged capillary refill time more than 5 seconds, and core to peripheral temperature gap more than 3 degrees Celsius. The American College of Critical Care Medicine recommends the use of bundles for the recognition, resuscitation, and stabilization of children with septic shock. Recognition of sepsis in pediatrics. If the child is suspected to have infection, assess whether the child has hypotension. If present, begin resuscitation. If there is no hypotension, assess whether worrisome features are present. If yes, begin resuscitation. If there is no hypotension or no worrisome features, proceed with routine care. This table lists abnormal vital signs according to age. Worrisome features is defined in this table. Heightened concern if more than 2 features or 1 feature with comorbid condition such as immunocompromised, recent surgery, indwelling central line, neonate less than 3 months, or underlying chronic disease. Features listed includes core temperature less than 36 or more than 38.5 degrees Celsius, altered mental status, altered peripheral perfusion, flash capillary refill less than 1 second, prolonged capillary refill more than 3 seconds, and presence of inappropriate tachycardia. Pediatric sepsis resuscitation algorithm. All these should be executed within the first hour of sepsis recognition. Begin high flow oxygen and place monitors. For monitoring, reassess every 5 minutes and after every intervention. Monitors includes pulse oximetry, ECG, heart rate with rhythm strip, blood pressure, core temperature, ventilatory frequency, and urine output. Clinical examination includes airway patency, work of breathing, crackles and rales, pulse and capillary refill, cardiac gallop, hepatomegaly, GCS, loss of consciousness, and peripheral skin temperature. Secure IV or intraosseous access, 2 large bore cannula, and send blood tests. Provide fluids and antibiotics. Fluids includes balanced crystalloid such as Ringer's lactate, 20 ml per kg times 3 push. Bloods to send includes sepsis panel, full blood count with differential, blood culture, blood gases and lactate, blood glucose and electrolytes, metabolic and DIVC screen, type and screen. Antibiotics includes ceftriaxone 50 mg per kg up to 2 grams, vancomycin 15 mg per kg maximum 1 gram, add metronidazole if intra-abdominal source is suspected 10 mg per kg maximum 500 mg. Therapeutic endpoints includes capillary refill 2 seconds or less, warm extremities, normal blood pressure for age, normal glucose, normal pulses, normal mental state, urine output more than 1 ml per kg per hour, and normal ionized calcium. Assess for fluid refractory shock. This may be divided into cold shock or warm shock. Signs of cold shock: cold extremities, prolonged capillary refill time more than 2 seconds, narrow pulse pressure, weak peripheral pulses, low cardiac output, and high SVR state. Treatment: adrenaline 0.05 to 0.3 mg per kg per minute, add noradrenaline if continued hypotension 0.05 to 0.3 mg per kg per minute, add milrinone if continued cold shock with normal BP 0.25 to 1 microgram per kg per minute. Signs of warm shock includes warm extremities, flash capillary refill less than 1 second, wide pulse pressure, low diastolic pressure, bounding pulses, high cardiac output, and low SVR state. Treatment is with noradrenaline 0.05 to 0.3 micrograms per kg per minute, add vasopressin if continued hypotension 0.002 to 0.2 units per kg per minute. Assess for catecholamine resistant shock. Rule out pneumothorax, cardiac tamponade, increased intra-abdominal pressure, more than 12 mmHg and blood loss. Assess for adrenal suppression, consider steroid replacement, consider hypothyroidism, consider thyroid replacement. If refractory shock, consider ECMO. If shock worsens or is resistant to fluid resuscitation, escalation of respiratory support should be considered. Causes of respiratory failure in pediatric sepsis includes pulmonary edema due to over-resuscitation with fluids, SIRS-induced capillary leak, sepsis-induced myocardial depression, pneumonia, etc. Comments on intraosseous access. IV or IO access should be attained within 5 minutes of sepsis recognition. Use of intraosseous access is contraindicated in children less than 3 years old. All IV medications can be given safely through the IO route, including emergency medications such as adrenaline, antibiotics, and blood products. An IO cannula functions similarly to an IV. Onset of action of medication is similar. It can be used for access for blood tests. All medications should be flushed with saline to ensure access to the vascular system. Fluids should be given continuously through the intraosseous cannula via infusion pump to avoid clotting. Abnormalities that might be seen in the patient's blood test includes hypoglycemia, acidosis, hypokalemia, hypocalcemia, hypomagnesemia, anemia, and coagulopathy. For patients with cardiogenic shock, such as having hepatomegaly, rales, crackles, cardiac gallop, or increased work of breathing, consider giving smaller initial fluid bolus of 5 to 10 ml per kg. For children who have hypoglycemia, provide dextrose 10% 10 ml per kg, IV or IO. Hypocalcemia should be treated to normalize ionized calcium concentrations with either calcium chloride 10 mg per kg or calcium gluconate 30 mg per kg. Although calcium chloride is more hypertonic, therefore irritating to peripheral veins, its onset of action is quicker than calcium gluconate, especially in the setting of liver dysfunction. Broad-spectrum antibiotics should be given to the child with sepsis within 1 hour of presentation. Ideally, blood cultures and other cultures should be sent before giving antibiotics. However, attaining IV access can be difficult in children with sepsis. An antibiotic administration should not be delayed. Antibiotics can be given intramuscularly. In toxic shock, antibiotic coverage should be broadened to include clindamycin due to its antitoxin properties. Once an organism has been identified, antibiotics should be narrowed in consultation with infectious disease service. Source control. In children with an identifiable source, early and aggressive source control is fundamental to management. Next is Anaesthesia sepsis algorithm. If the child has suspected infection, refer to sepsis recognition algorithm. If the child has not received appropriate resuscitation, refer to sepsis resuscitation algorithm and execute as appropriate. If the child has received appropriate resuscitation for sepsis, proceed with pre-op optimization, IV access ×2 or central access. Intraosseous is inappropriate for surgery due to high risk of dislodgement. Consider securing central venous catheter under sedation prior to induction, especially if receiving peripheral catecholamine infusions. Consider transfusing PEG cells so that hemoglobin is more than 10 grams per deciliter. Correct coagulopathy with platelets, fresh frozen plasma or cryoprecipitate as required. Correct hypoglycemia with dextrose, 10%, 10 ml per kg. Correct electrolyte and acid-base abnormalities, such as hypocalcemia, hyperkalemia, and consider sodium bicarbonate if pH is less than 7.2. Assess antibiotic coverage, whether it is appropriate or not. Induction. Pre-oxygenate the lungs. Prior to induction, consider fluid boluses and vasopressor infusion and boluses prepared. Consider giving preemptively before induction medications. Consider invasive monitoring, arterial and central venous access. Prioritize titration of medications on induction over potential risk of aspiration. Intraoperative management, titrate anesthetic and hemodynamic medications to achieve adequate depth of anesthesia, adequate pain control, SCVO2 more than 70%, lactate less than 2, HB more than 10 grams per deciliter, normal pH and electrolytes, normal blood pressure, heart rate, temperature and capillary refill. Repeat antibiotics every 2 half-lives. Lung protective ventilation strategy. Post-op considerations. Continued intubation with lung protective ventilation strategy. Pain control. Continued hemodynamic monitoring. Transfer to pediatric ICU. Involve intensivist and infectious disease specialist input if not already involved in the care. Sepsis can dramatically alter drug pharmacokinetics, potentially affecting pharmacodynamics. Care must be taken to adjust medication choice and dosage to avoid unexpected effects and iatrogenic harm. Drug absorption from both enteral and non-enteral routes are unpredictable in sepsis. Medications are best given IV, as altered blood flow to the gut, skin, and muscles due to changes in circulation can impair oral or subcutaneous absorption. Distribution may be affected by changes to tissue perfusion, tissue membrane permeability, protein binding, body water distribution, tissue mass, and pH. Metabolism of most commonly used anesthetic medications primarily occurs in the liver. It may also occur in the kidneys and lung. Sepsis is associated with hepatic dysfunction. Metabolism is affected by altered hepatic blood flow, free unbound drug fraction, and hepatocyte intrinsic activity. Clearance of medications with high hepatic extraction ratios is altered primarily due to hepatic blood flow changes. Clearance of medications with low extraction ratios is altered by drug protein binding and hepatocyte function. Renal excretion of medications and their metabolites may be altered by sepsis-induced renal injury, which may be pre-renal and post-renal in etiology. Comments on specific medications used in anesthesia. Ketamine. Reduce induction dose 0.25 to 0.5 mg per kg. Give slowly and titrate to effect. Ketamine has direct myocardial depressant effects. In children with sepsis and who are adrenergically depleted, ketamine may cause profound CVS depression. Hepatic impairment may prolong the effects of ketamine. Consider giving both inotropes and vasopressors or fluid boluses to counteract cardiovascular depressant effects. Benzodiazepines. Reduce induction dose, such as midazolam 0.05 to 0.1 mg per kg. Titrate to effect. Infusions should be given with caution. Hepatic and renal dysfunction prolongs its effects. Reduced serum albumin concentrations may enhance the effects of benzodiazepines. Consider giving both inotropes and vasopressors and fluids to counteract CVS depressant effects. Opioids. Dose should be reduced and titrated to effect. Consider using opioids in combination with other agents to reduce dosage requirements of each. Sepsis-related changes in volume of distribution may prolong the effects of these drugs. Hepatic hypoperfusion causes reduced clearance of opioids, prolonging their effects. Metabolism of remifentanil is unchanged in sepsis. Consider giving inotropic and vasopressor drugs and fluids to counteract the CVS depressant effects. Propofol. Caution for use in patients with sepsis who have CVS instability. Induction dose should be lowered 0.5 to 1 mg per kg, given slowly and titrated to effect. Propofol can cause profound CVS depression. Induction may be prolonged due to sepsis-induced cardiomyopathy. There is higher risk of propofol infusion syndrome. Infusion dose should not exceed 4 mg per kg per hour. Consider giving both inotropic and vasopressor support and fluids to counteract CVS depressant effects. Regarding rocuronium, hepatic dysfunction, hypoalbuminemia, and electrolyte abnormalities, acidosis and hypothermia prolong the effects of rocuronium. There is unpredictable duration of action in sepsis. There is a necessity for neuromuscular monitoring and ensuring adequate reversal, for example with sugammadex when appropriate. For saxametonium, avoid use in children with sepsis, underlying hypotonia, renal injury with associated hyperkalemia, rhabdomyolysis, or prolonged immobility. Sepsis may result in acquired plasma cholinesterase deficiency. Unpredictable duration of action necessitates neuromuscular monitoring. For completion, influence of organ system pathology on pharmacodynamics and pharmacokinetics is included here. Pharmacokinetic changes in critical illness. PK/PD changes in airway pathology. PK/PD changes in respiratory pathology. PK/PD changes in CVS pathology. Neurological pathology. Electrolyte and acid-base derangement. Renal pathology. Hepatic pathology. GI pathology. Obesity. Infectious pathology. Hematological pathology. Endocrine pathology or environmental effects. Are included here for completion, mainly referenced from derangedphysiology.com. These are my references. Thank you.